Hello and welcome to the topic Lichen Planus in the Dermatology module. By the end of this topic, you should be able to define Lichen Planus, explain the pathophysiology of Lichen Planus, outline the causes and classification of Lichen Planus, describe the clinical manifestations and investigations done for Lichen Planus, discuss the principles of management and the complications as well as the prognosis of Lichen Planus. Let's get started. The term lichen originates from the Greek term lichen, which means what eats around itself, while planus is a Latin term that means flat or plain. It is not an actual lichen, but it is named so because it looks like one. It is a chronic inflammatory and immune-mediated disease that commonly affects the skin, nails, hair, and mucous membrane. The skin is an important immune organ. Its function extends more than just being a physical barrier that prevents entrance of allergens and pathogens. It also acts as an active immune organ. Although the epidermis has no direct access to the blood or lymphatic circulation, it is equipped with immune-competent cells known as Langerhans cells. It is a macrophage-like antigen-presenting cells of the epidermis. In addition, keratinocytes are epithelial cells with immune properties. Dendritic epidermal T lymphocytes are resident cells of the epidermis that may serve as a primitive T-cell immune surveillance system. Epidermotrophic lymphocytes migrate from vessels in the dermis when needed. And lastly, melanocytes are epidermal pigment cells with immune properties. These properties allow skin to function as an immune organ. When skin is being exposed to triggers such as drugs or viral infections, there will be hypersensitivity reaction. This results in T-cell mediated chronic inflammatory tissue reaction and causes cytotoxic reaction against epithelial basal cells. Another hypothesis that have been proposed is upregulation of matrix metalloproteinases, which disrupt epithelial basement membrane and allow entry of immune cells into the epidermis, which then leads to the damage of the skin layer. Contributing factors of lichen planus are hypersensitivity reaction triggered by drugs or medication, systemic viral infections including hepatitis C, and localized skin infections such as herpes zoster infection. Injury to the skin due to scratching or surgery and genetic predisposition also increases risk of lichen planus. Lichen planus has different clinical types, but they share similar features of histopathology. Its classification are cutaneous, mucosal, lichen planopilaris, lichen planus of the nails, lichen planus pigmentosus, and lichenoid drug eruption. Patients will commonly complain of intense itch and skin changes or lesions. Examination of the lesion reveals surface that is papules or polygonal plaques which are shiny. Its top is flat and firm on palpation. Scaly plaques often are crossed by fine white lines known as the Wickham striae. The size ranges from pinpoint to larger than a centimeter. It is more commonly found on sun-exposed sites such as the face, neck, and backs of the hands. It may be scattered, clustered, linear, annular, or actinic in distribution. The lesion is of purple and violet hue except on the palms and soles where they are yellowish-brown. However, one should keep in mind that skin color may affect the lesion color differently. Pathognomonic sign of lichen planus is papules and polygonal plaques that are shiny with flat top and is firm on palpation. Skin lesions should be thoroughly examined before proceeding with skin biopsy. Skin biopsy is essential to confirm diagnosis and to look for presence of cancer. The typical features seen on skin biopsy are irregular thickened epidermis, degenerative skin cells, and liquefaction, degeneration of the basal layer of the epidermis. Other features include band of inflammatory cells and melanin just beneath the epidermis. Direct immunofluorescence staining will show deposits of immunoglobulins at the base of the epidermis. Medical management is not always necessary and is targeted for local skin treatment, while systemic treatment is to prevent further widespread progression of the lesion. Local management of the lesion include use of potent topical steroids, topical calcineurin inhibitors or tacrolimus ointment, topical retinoids, and intralesional steroid injections. Systemic therapy include medications such as hydroxychloroquine, methotrexate, azathioprine, mycophenolate mofetil, and phototherapy. Acute complications of lichen planus is superimposed bacterial or fungal infections that require immediate medical treatment. Chronic lichen planus will result in hypertrophic lesions that resemble squamous cell carcinoma and transformation into true squamous cell carcinoma, especially if eroded. Squamous cell carcinoma is more commonly seen in smokers, those with history of cancer at mucosal sites, and in those who have acquired oncogenic human papillomavirus through sexual contacts. Cutaneous lichen planus usually resolve within 6 months to 1 year, while hypertrophic variants tend to persist for years if left untreated or unmonitored. Let's summarize. Lichen planus is a chronic inflammatory immune-mediated disease of the skin which leads to formation of a violaceous papule and plaques with overlying reticulated fine white scales. The lesion is due to T-cell mediated response which result in cytotoxic reaction against epithelial basal cells. Lichen planus is caused by environmental exposure to drugs, injury, toxins, and infections in genetically predisposed individuals. Examination of the lesion reveals well-defined area of purple-colored, itchy, flat-topped papules with interspersed lacy white lines which are known as Wickham striae. This description is known as the characteristic 6 Ps of lichen planus, which are planar, meaning flat-topped, purple, polyclonal, pruritic, papules, and plaques. Skin biopsy is essential to confirm the diagnosis of cutaneous lichen planus, and the management is directed towards symptomatic relief or for cosmetic reasons. We have come to the end of this topic. Thank you.